Level up your AI skills with the RSNA Imaging AI Certificate Program. Our case based courses are designed to help you gain confidence, improve efficiency, and advance your career in this rapidly evolving field. Due to popular demand, we're extending our special RSNA member only offer of 25% off enrollment for any AI certificate course with promo code MEMBERAI25. Learn more at rsna.org/AI-certificate. This special offer ends November 29th, so act now.
Hi, everyone. Welcome back to another RSNA Radiographics podcast. My name is Lily Wang. I'm your host for today. I'm a neuroradiologist at the University of Cincinnati. Today's podcast guest is Dr. Aakanksha Sriwastwa. She's a neuroradiologist at the University of Cincinnati. Today, we are going to talk about the review article authored by Amit Desai and colleagues from Mayo Clinic, Jacksonville, Florida. The topic is motor neuron disease and CNS tractopathies, clinical radiologic correlation and diagnostic approach. Thank you for joining me on this podcast.
Thank you, Lily, for having me to discuss this very comprehensive and well-written article.
This article has great clinical and radiologic descriptions and imaging examples of multiple etiologies causing CNS tractopathies and upper and lower motor neuron diseases. Let's dive in, shall we?
Totally.
First, what are CNS tractopathies and can you briefly discuss their spectrum?
Sure. So, CNS tractopathies are abnormalities affecting the ascending and descending CNS tracts. These constitute primary disorders including amyotrophic lateral sclerosis and its variants, and numerous secondary disorders related to nutritional myelopathies, drugs, leukodystrophies, infection, and immune-mediated disorders. Now, each of these conditions is associated with unique clinical and radiological features and diagnostic challenges. A comprehensive multidisciplinary review of patient history, physical examination findings, lab results, and advanced neuroimaging findings are crucial for an accurate diagnosis and to enhance patient care and prognosis.
Okay, well, that sounds like a really wide spectrum. Can you briefly explain the neuroanatomy affected by these disorders?
Happy to. The CNS white matter is organized into two primary types of tracts. The ascending tracts carry sensory input and include the dorsal columns, the lateral and anterior spinothalamic tracts, and the dorsal and ventral spinocerebellar tracts. The second type is the descending tracts that carry the motor output from the cortex to the peripheral nerves. These include the corticospinal, corticobulbar, vestibulospinal, rubrospinal, and reticulospinal tracts. From a radiologist's point of view, we can study these tracts using conventional MRI and by dedicated diffusion-based MRI tractography.
What are the four subsystems of motor neurons?
So the four subsystems include upper motor neurons, whose cell bodies reside within the cerebral cortex and brainstem, then the lower motor neurons, whose cell bodies reside within the brainstem and gray matter of the spinal cord, and then the cerebellum and the basal ganglia.
How do upper and lower motor neuron lesions manifest clinically?
So the cell bodies of upper motor neuron reside in the cerebral cortex and brainstem, like we know. The subset of upper motor neurons that terminate on the brainstem lower motor neurons, that is the cranial nerves, are referred to as the corticobulbar tract, where the bulbar refers to the brainstem. The remaining upper motor neuron white fiber tracts, referred to as the corticospinal tract, continue their descent through the ventral pons and medullary pyramids, where 90% of them decussate and ultimately terminate within the spinal cord. When the upper motor neurons are damaged in the acute phase, the patient may experience spinal shock, that is a transient severe loss of the strength, tone, and reflexes of the affected muscle. After several days, this is followed by muscle spasticity, clinically evident as hyperreflexia, increased muscle tone, muscle clonus, and usually minimal or no muscle atrophy. Imaging-wise, this may be seen as atrophy or T2 hyperintensity along the course of the corticospinal tract within the cerebral hemispheres, including precentral gyrus, brainstem, or lateral and anterior columns of the spinal cord. On the other hand, lower motor neurons are the final common pathway for initiating movement. Their damage results in weakness, loss of muscle reflexes, decreased muscle tone, and eventually atrophy or fatty replacement of the innervated muscle. As a result, on imaging, we may see muscle atrophy or volume loss within the anterior horns of the spinal cord.
Thank you. So let's discuss the primary CNS tractopathies now that we have some grasp on the neuroanatomy involved.
Yes, let's do it. So, the most important and most common primary CNS tractopathy is amyotrophic lateral sclerosis, which will be referred to as ALS henceforth. It is an acquired motor neuron disease involving both the upper and lower motor neurons of the extremities, torso, and head and neck. Additionally, there are several ALS variants based on what's involved. Some affect only the upper motor neurons, for example, primary lateral sclerosis. Some affect only the lower motor neurons, for example, progressive muscular atrophy or spinal muscle atrophy. And some affect the motor neurons of the head and neck, for example, progressive bulbar palsy.
Can you describe a few clinical and imaging features of ALS for us?
Sure. So, ALS is a progressive neurodegenerative disorder affecting 4 to 5 people per 100,000 individuals globally, slightly more common in males, with an average age of onset in the fifth to sixth decades of life. 90% of ALS cases are acquired and approximately 10% are familial. ALS diagnosis requires the presence of both upper and lower motor neuron signs, which may include progressive bulbar symptoms, spastic paraparesis, and or flaccid paraparesis without sensory deficits.
What can we see on imaging in ALS?
So on MRI, susceptibility-weighted MR images show the motor band sign, a hypointense signal along the cortex of the precentral gyrus, secondary to intracellular and extracellular deposits of iron, with a sensitivity and specificity of 60% and 91% respectively. T2 flare hyperintensity along the corticospinal tracts may be seen in approximately 30% patients with ALS, and these have a positive correlation with the disease progression. Now, T2 hyperintensity of the lateral columns of the spinal cord have also been reported. Interestingly, 5 to 15% of patients with ALS can have frontotemporal dementia associated due to overlapping molecular mechanisms involving TDP-43 proteinopathy.
That's good to know, Aakanksha. Can you shed some light on the various variants of ALS that you were mentioning?
Yes. So primary lateral sclerosis is a variant of ALS that affects only the upper motor neurons and will present with spasticity, stiffness, dysarthria, and sometimes pseudobulbar effect. Age of presentation is between third and seventh decades of life, and the prognosis is better than typical ALS. On MRI, similar to ALS, iron deposition can be seen in the primary motor cortex, or hyperintensity can be seen along the corticospinal tracts and precentral gyrus.
So, what does ALS variant, which only affects the lower motor neuron, look like?
The MRI findings of the lower motor neuron variant include atrophy and T2 hyperintensity of the anterior horns, with sparing of the corticospinal tracts. Usually, they have a more favorable prognosis compared to ALS.
And how about progressive bulbar palsy?
So, progressive bulbar palsy will have only bulbar involvement and will present with rapid onset bulbar symptoms. Motor bag sign is also seen, and notably, this involves only the lateral precentral gyrus corresponding to the facial region.
Now, tell us a little bit about spinal muscular atrophy.
Spinal muscular atrophy is a lower motor neuron disease affecting the anterior horn cells of the spinal cord. Now, SMA types 1 to 3 have a childhood onset and a more severe clinical presentation. MRI in these can demonstrate atrophy of the anterior horns of the spinal cord with preservation of the corticospinal tracts, as well as atrophy of the proximal muscles involved.
Okay, well, thank you for going over the primary tractopathies comprising of ALS and its variants. Let's discuss some of the secondary causes of tractopathies.
Sure. So, causes for secondary tractopathies, as we mentioned, can include toxic and metabolic disorders. They can be drug induced, they can be due to vitamin deficiency, infectious causes, immune mediated disorders, or genetic disorders.
That's a pretty wide spectrum. Can we start with some of the vitamin deficiencies and metabolic causes?
Certainly. So, the first one I would like to mention here is subacute combined degeneration. This is caused by vitamin B12 deficiency, as we know, and involves both central and peripheral nervous systems. Hence, the name includes the term combined. Patients present with signs of dorsal column involvement, such as impaired position and vibration sense. However, only 20% of these demonstrate symmetric T2 hyperintensity involving the dorsal columns with or without involvement of the lateral corticospinal tract. Notably, with vitamin replacement therapy, these signal intensity abnormalities typically improve. However, the neurologic signs may persist despite resolution of the MRI abnormalities.
What are some entities that can look very similar to subacute combined degeneration on imaging?
I'm glad you asked that. Copper deficiency myelopathy and nitrous oxide induced myelopathy are clinically and radiologically indistinguishable mimics of subacute combined degeneration. Copper deficiency can be seen in clinical scenarios such as gastric bypass surgery, hemodialysis, malabsorption, nephrotic syndrome, and zinc toxicity. Nitrous oxide is an anesthetic agent, and myelopathy can be seen in post anesthesia settings in patients with borderline or low levels of vitamin B12, simply because nitrous oxide irreversibly inactivates this vitamin.
What are some liver disease related encephalopathies?
So, among the metabolic causes other than vitamin deficiencies, we have acquired hepatocerebral degeneration in patients with hepatic dysfunction and cirrhosis that can lead to secondary tractopathies. This can result in relapsing episodes of encephalopathy and pyramidal and extrapyramidal signs like Parkinsonism, athetosis, myoclonus, and asterixis. There can be nonspecific T2 hyperintensity along the hemispheric and subcortical corticospinal tract, which is caused by edema, not demyelination, and therefore usually resolves after liver transplant. 90% of patients have symmetric T1 hyperintensity in globus pallidus and substantia nigra due to manganese deposition.
Looks like correlation with clinical history and recent history of anesthesia is crucial when we are dealing with imaging for suspected tractopathies. Kansha, can you elaborate on some of the toxic causes for CNS tractopathies?
So, two of the relatively common clinically encountered toxic etiologies of tractopathies are inhalational heroin associated spongiform leukoencephalopathy and chemotherapy related leukoencephalopathy. Now, both of these entities demonstrate a predilection for corticospinal tract involvement. Inhalational heroin toxicity, referred to as chasing the dragon, can be seen on MRI as bilateral symmetric T2 hyperintensities predominantly within the coronary radiata, posterior limb of the internal capsule, white matter of the occipital lobe, splenium of the corpus callosum, and cerebellar white matter. The brainstem is frequently involved with T2 hyperintensity involving the corticospinal tract, solitary tracts, and central tegmental tracts. Chemotherapy, for example, methotrexate or capecitabine, can lead to restricted diffusion and T2 hyperintensity involving the splenium, thalami, posterior parietal periventricular region, and corticospinal tracts.
How about genetically mediated tractopathies?
Yes, so there are multiple genetically mediated tractopathies. Some of these are Krabbe's disease, adult polyglucosan body disease, metachromatic leukodystrophy, X-linked adrenal leukodystrophy, Alexander's disease, autosomal dominant leukodystrophy, Leber's hereditary optic neuropathy, and Friedreich's ataxia, to name a few. While the connecting feature is that all of these involve some part of the CNS tracts, varying from isolated or multifocal and contiguous involvement of the corticospinal tracts, internal capsule, brainstem, cerebellum, and spinal cord. Many of these etiologies have unique imaging features and are unique clinical presentations.
Interesting. Kansha, can you please explain with some examples of the important ones? Because there's quite a few.
Yeah, sure. So, adult polyglucosan body disease, for example, is an autosomal recessive neurodegenerative disorder caused by disruption in glycogen synthesis and accumulation of polyglucosan bodies in the nervous system tissue. Affected patients typically present with urinary incontinence, secondary to neurogenic bladder, in their fifth decade of life, followed by progressive spastic paraparesis and peripheral sensory motor neuropathy. Imaging findings include symmetric T2 hyperintensity in the corticospinal tract from the posterior limb of the internal capsule to medulla in approximately 80%, with atrophy of the medulla and spinal cord.
How about autosomal dominant leukodystrophy?
So, autosomal dominant leukodystrophy has urinary continence as their first symptom as well. This is caused by disruption in the oligodendrocyte maturation, and the patients initially present with progressive urinary retention, urgency, erectile dysfunction, and signs of postural hypertension, with the cerebellar and pyramidal signs usually appearing later. Imaging different demonstrates diffuse and symmetric T2 hyperintensity in the frontal and parietal white matter, corticospinal tracts, corpus callosum, cerebellar peduncles, with homogeneous white matter T2 hyperintensity and marked thinning involving the entire spinal cord.
Can you tell me about adult onset Alexander disease?
Sure. So when patients present with palatal myoclonus, ataxia, bulbar symptoms, and dysautonomia, adult onset Alexander disease is one of the clinical considerations. MRI typically shows T2 hyperintensity and progressive atrophy of the medulla and cervical spinal cord. The cerebellum, nodocerebellar peduncles, and corticospinal tracts are also frequently involved, and enhancement may be present, which may mimic a demyelinating disease.
How about Friedreich's ataxia? What does that look like?
So, Friedreich's ataxia is another recessive inherent disorder resulting in slowly progressive ataxia. Deep sensory abnormalities, cardiomyopathy, dysarthria, and a high incidence of diabetes mellitus can also be seen. Friedreich's ataxia classically affects the dorsal root ganglia and spinal dorsal columns, with degeneration of the spinocerebellar tracts and cerebellum. T2 hyperintensity in the middle cerebellar peduncle and splenium, with symmetric hyperintensities extending from the pons to the dorsal and lateral columns of the cervical spinal cord, can be seen. The review article actually comes with imaging examples of these and many other genetic CNS tractopathies, so I would really request all our listeners to definitely check that out.
Yeah, I agree. It's such a beautifully written paper with excellent illustrating examples, especially some of the rare disease that you don't see all the time. So it'd be great to visit the paper, check out the figures and the flow charts. Figure 18 is great. It talks about differential diagnosis for cortical spinal tractopathy based on the pattern of brain and spinal cord involvement on imaging. So that's super helpful.
I know, right? So I would probably use that as a ready reference the next time I come across a weird case of possible CNS tractopathy.
Yeah, let's switch gears from genetic disorders. Can you talk about immune mediated and demyelinating disorders that we should keep in mind when CNS tracts are involved?
Yeah, so I would say neuromyelitis optica, neurobetchett's disease, and some of the paraneoplastic syndromes are the big ones here. Neuromyelitis optica spectrum disorders have a wide range of manifestations, including optic neuritis, long extensive segment transverse myelitis, area postrema syndrome, narcolepsy, and cerebral syndrome. On imaging, there is a predilection for periventricular and circumventricular areas, corpus callosum, and corpus-spinal tracts. Now, switching gear to Behçet's disease, which is an idiopathic multisystem vasculitis. It's classically characterized by the triad of oral ulcers, genital ulcers, and uveitis. Neurobehçet disease lesions may be extensive or scattered and involve the internal capsule, thalami, midbrain, pons, medulla, basal ganglia, and cerebellum. Paraneoplastic myelopathy can be seen with breast and lung cancers. The hallmark feature on imaging is extensive symmetric T2 hyperintensity with accompanying enhancement in the lateral columns or less commonly the dorsal columns of the spinal cord.
There are several infectious diseases that can cause CNS tractopathy. Let's talk about the infectious causes.
Definitely. Whipple's disease, progressive multifocal leukoencephalopathy, HIV-related vacuolar myelopathy, COVID-19 infection, and arboviruses are some of the infections the authors have touched upon in this article. Whipple's disease is a multisystemic chronic infectious disease that predominantly affects the gastrointestinal system and nervous system in men in their sixth decade typically. CNS symptoms include oculomasticatory myarrhythmias, dementia, ophthalmoplegia, ataxia, and motor and sensory deficits. Neuroimaging findings can be again nonspecific and show bilateral asymmetric T2 hyperintensity with minimal enhancement in the mesial temporal lobe, inferior frontal lobe, midbrain, hypothalamus, and occasionally the corticospinal tracts.
So PML is another infectious CNS agent. What does PML look like?
So PML, as we know, can have multifocal asymmetric involvement of the subcortical and periventricular white matter that may extend along white matter tracts such as the arcuate fasciculus, corticospinal tract, and corpus callosum. Patchy hyperintensity around the lesion, termed the Milky Way sign, if present, is characteristic of progressive multifocal leukoencephalopathy. Isolated pyramidal tract involvement has also been reported in several cases.
How about HIV?
So, HIV-related vacuolar myelopathy may occur in an acute transient form at the time of seroconversion or in a chronic vacuolar progressive form in the late stage of HIV infection. Bilateral symmetric non-enhancing T2 hyperintensities involving the dorsal columns resembling subacute combined degeneration along with cord atrophy can be seen.
How about other viruses?
Now, Zika and West Nile viruses can affect the anterior horn cells predominantly and manifest as linear T2 hyperintensities. With COVID-19 infections, apart from encephalomyelitis, stroke, and Guillain-Barré syndrome, rapidly progressive myelitis with predominant involvement of the dorsal and lateral columns have also been reported.
Those were really extensive list of etiologies causing CNS tractopathies. What is the take-home point for radiologists?
Yeah, sure. So, analyzing radiologic findings within the context of clinical symptoms is the key in the workup of motor neuron diseases. ALS or an ALS variant should be considered in patients who have purely motor neuron symptoms and imaging findings confined to the precentral gyrus and are corticospinal tract. In patients with purely lower motor neuron signs, imaging may reveal only muscle atrophy or volume loss in the antehorns of the spinal cord. And progressive muscular atrophy or spinal muscular atrophy should be considered in these cases. When upper motor neuron signs coexist with sensory neuropathy, on the other hand, another tractopathy should be considered based on the specific sensory symptom that may help to quickly narrow the differential diagnosis, like we elaborated previously. Specific patterns of brain and spinal cord involvement can help narrow the differential diagnosis.
Okay, well, our listeners are armed with knowledge now, so they ready to narrow down the differentials on brain and spine MRIs for these patients.
I surely hope so. I for sure feel more confident having discussed these in detail now.
Yeah, that's wonderful. Aakanksha, thank you so much for your time. I have really enjoyed talking with you about the clinical radiologic correlation and diagnostic approach for motor neuron disease and CNS tractopathies. It is a mouthful. Thank you for your attention. Please check out the article on Radiographics website for the images and see you at the next episode of the podcast. Bye.